Okay, let's keep moving on. We are still in chapter 3 on drug interactions. We're on page 63 in the chart entitled Drugs with Additive Risk. So we have 3 columns. The columns are entitled Additive Side Effect, Risk, and then Actions, Notes. So on this page 63, we have a section for serotonergic toxicity, we have a section for bleeding, and then we have a section for hyperkalemia. So let's go ahead and start with bleeding, because that is something that I did on my first rotation in the CCU. So let's take a look at anticoagulants. So we have warfarin, we have apixaban, we have rivaroxaban, heparin, enoxaparin, dalteparin. So we have all of our anticoagulants, and then we have our antiplatelets. So we're thinking aspirin, we're thinking clopidogrel, we're thinking of dipyridamole, we're thinking of NSAIDs. So we know of our ibuprofen, naproxen, diclofenac, indomethacin. So let's also take a look at natural products. So some things that affect bleeding are things like garlic, ginger, ginkgo, ginseng, glucosamine. So you can remember that by the 5 G's. Again, ginger, garlic, ginkgo, ginseng, and glucosamine. Also under natural products, think fish oil, think vitamin E, and willow bark. Another thing that is often forgotten that it does affect bleeding is the SSRIs and the SNRIs. So think fluoxetine, citalopram, escitalopram, paroxetine, sertraline, duloxetine, venlafaxine. So what's the risk with these anticoagulants, antiplatelets, NSAIDs, natural products, SSRIs and SNRIs? So the risk is that they increase your bleed risk. So increased bleed risk can occur with or without changing an anticoagulation monitoring parameter, such as the INR with warfarin. So what type of actions should be taken? So avoid using in combination, but then there are a few exceptions. So there's 4 exceptions noted here. So the first exception, aspirin. So for cardioprotection, aspirin is okay. And for occasional NSAID use for like pain or for a headache or fever or inflammation. So here's another exception. As dual antiplatelet therapy, it might be recommended for some patients to prevent like cardiac stent thrombosis. Here's a third exception. Bridging and overlap treatment, such as with enoxaparin and warfarin, until the INR might reach therapeutic levels, which could take more than 24 hours. And then here's the fourth exception. So like with SSRIs and SNRIs, when using those, and occasional NSAID use for pain, fever, and or inflammation. All right, so let's also look at this topic of hyperkalemia, which is increased potassium levels, which is something we really monitor, like in the CCU. So, which was my first rotation. So let's see. Let's go back and discuss the renin-angiotensin-aldosterone system drugs, potassium-sparing diuretics, and we'll look at some other medications that affect hyperkalemia. So first we're going to talk about the renin-angiotensin-aldosterone system drugs. So we're thinking ACE inhibitors, ARBs. We're thinking spironolactone for sure. When we think about potassium-sparing diuretics, we're thinking amiloride, triamterene. We're not thinking about Lasix, right? We're not thinking about furosemide because that would cause hypokalemia. That would lower the potassium levels. So what are some other things that can increase potassium levels? Salt substitutes, calcineurin inhibitors like tacrolimus and cyclosporin that a lot of the kidney transplant patients take. The antibiotic Bactrim, right? And some of the drospirenone containing birth control tablets. Also how do you say this? I can never say it properly. Canagliflozin, so one of the diabetes medications. So let's look at risk. So the risk is already stated. The risk is high potassium. What do the symptoms look like though? Symptoms look like heart palpitations, arrhythmia, and there is a particular note that there is higher risk if a patient is in renal impairment. So I'm going to star and circle this. So what do the notes say? And what type of actions and monitoring parameters are there? So do not use ACE inhibitors with ARBs. That is something that sometimes would be asked, like working in the CCU. Sometimes professors would say or ask students, can you use them together? Is there any literature that suggests that there's a demonstrated benefit? Have there been clinical trials saying that, there's benefit in using ARBs and ACE inhibitors together? Well, in patients that maybe, struggle with a lot of occurrences of atrial fibrillation and are being managed for that, definitely don't enroll them in any of those clinical studies where they're evaluating the potential benefits of using ACEs and ARBs together, okay? Because it'll throw them into an arrhythmia. Don't use sacubitril valsartan with ACE inhibitors or ARBs either, okay? So don't use that combo medication of the ACE-ARB with the ACE inhibitors and ARBs. So again, be careful with the combos. If risk of hyperkalemia, so if there's risk, suggest alternatives to the diabetes medication canagliflozin. Suggest alternatives to Bactrim for infection, or suggest an alternative to any of those drospirenone containing birth control tablets. And then you want to definitely let the patients know to avoid any of those salt substitutes. Maybe they're a worker that sweats a lot outside and loses electrolytes. they would want to be careful if they're prone to arrhythmias. You know, maybe they need to definitely avoid certain salt substitutes and electrolyte replenishment salt products that you could buy behind the counter that contain, you know, potassium chloride, KCl. So I'm going to actually circle that one because we would have, when I worked in Phoenix, we would actually have some landscapers come into the 24-hour pharmacy and ask for the salt tablets. And so that is very important. We would have translators, technicians in our store to make sure, you know, that they don't have arrhythmias. And so monitor potassium. All right. So that one is the hyperkalemia. The last topic on this page 63 is let's see, serotonergic toxicity. All right, so let's get into it. We have 1, 2, 3, 4, 5, 6 areas we're going to talk about with serotonergic toxicity. So first and foremost, as we know, antidepressants. We also have opioids. We're also going to be looking at MAOIs, triptans, natural products, and then of course we have the heading of other, which is just, you know, a whole bunch of medications of all different categories. Okay, so let's look at some of the examples of antidepressants that can cause serotonergic toxicity. So we know the SSRIs, the SNRIs, the tricyclics, mirtazapine, trazodone. Then we have our MAOIs. So we have phenelzine, tranylcypromine, isocarboxazid. We have our selective MAO-B inhibitors like selegiline and rasagiline. We also have linezolid and methylene blue. Then we have some opioids like fentanyl, meperidine, methadone, tramadol, tapentadol. We also are looking at our triptans like there's a note here, occasional as needed triptan use may be safe. More frequent use would of course increase risk of serotonergic toxicity. The natural products that we're reminded about are definitely something we talked about in the previous chapter. So L-tryptophan, okay? We remember that one. So tryptophan is that precursor to serotonin. And again, St. John's wort can cause serotonergic toxicity. In terms of other medications that can lead to serotonergic toxicity, we're thinking lithium. We're thinking buspirone. We're thinking excessive amounts of dextromethorphan. All right, so what's the risk? So serotonin syndrome risk increases when 2 or more drugs that affect serotonin are used together. Higher doses will increase risk. Symptoms can range from mild to severe to fatal. So what should we expect if this is what's going on? So there can be autonomic dysfunction like diaphoresis, nausea, vomiting, hyperthermia. There can be altered mental status like akathisia, anxiety, agitation, delirium. There can be neuromuscular excitation like hyperreflexia, tremor, rigidity, tonic-clonic seizures. All right, so actions by pharmacist, actions and notes and reminders. So what should the staff do? Well, we want to make sure that we are avoiding using serotonergic medications concomitantly. So if they do happen to be used together, like when we review the profile, the doses really need to be lower and within recommended ranges. Check for inhibitors of serotonergic drugs, because that would lead to the higher levels, which could cause big problems. And counsel the patient to report symptoms even if they're mild. So if there are severe symptoms, we need to remind the patient that they have to go to the emergency room. Recommend eliminating any initial serotonergic drugs prior to starting a new serotonergic drug by using a washout period. Use 2 weeks between the drugs, and again 5 weeks for the drugs with the longer duration of action, for example with Prozac. And that will wrap up the chart on page 63.